Let's move on to a discussion about the different hearing support systems and technologies that are available out there. There's really been some tremendous changes over time, starting with simple hearing aids that have gone from analog systems to digital hearing aids now. And sometimes those simple or relatively complex changes in the technologies have made dramatic improvements. One of the starting points for hearing aids is that their basic function is to increase the volume of what patients hear. So it still requires that you're using the native hearing of a child and whatever residual hearing is left, and then increasing it by the use of the hearing aid in the ear. In the old days, the analog hearing aids had very little filtering capabilities. So parsing out the signal that someone was trying to listen to relative to all the background noise was sometimes very difficult. In addition, it was rare that children would have a flat hearing loss where across the frequency spectrum from low-pitched tones to high-pitched tones, the hearing was equal. In contrast, people are much more complex than that, and in general, they tend to have very sloping or irregular audiograms, where some frequencies, some pitches hear better than others. With analog hearing devices, you really didn't have as much capacity to change and selectively amplify or not amplify certain regions of the hearing spectrum. With digital hearing aids, that's been dramatically improved. What that means for the person wearing the hearing aid is that they can hear things much clearer, and specifically the speech recognition ability and the ability to understand spoken language is dramatically improved. And if we're looking overall from a more global perspective of how to improve someone's communication ability, that auditory ability to understand speech and language is obviously key. One of the important things to know about hearing aids is that they're probably the most adaptable and most relevant form of hearing intervention or support for a person with hearing loss. The reason for that is that you can look at it in terms of what conditions is it applicable for, as well as you always consider any type of intervention in clinical medicine from a risk-benefit perspective. If I start with that one, a risk-benefit analysis of hearing aids is tremendously favorable because there's really no medical or surgical risk associated with wearing a hearing aid. The only caveats that an audiologist or a clinician has to pay attention to is to make sure that they don't over-amplify things and cause some noise-induced hearing loss. But thankfully, with accurate hearing testing and good hearing aid programming, that's really not a concern. The other interesting or valuable aspect about hearing aids is they can compensate for a very mild hearing loss. And in some kids and patients, they can actually compensate for a severe to profound hearing loss. So there's a huge range of what the audiologist will call power options. For patients with mild hearing loss, they can provide a very little degree of power. But those patients who have more severe to profound hearing losses, the hearing aids can be programmed to provide a tremendous amount of power. There's not always that latitude with other types of hearing interventions. So that's one of the things that makes hearing aids in a traditional fashion so much beneficial and interesting to most patients. If you go on from there and specifically relevant to the setting of charge, one of the interesting hearing options is a bone-anchored hearing aid. And this is shown in the following slide. A bone-anchored hearing aid consists of two different parts. And this can be used in several different fashions that I'll explain. So in the most common manner, patients who have a conductive hearing loss, and just to retrace a little bit from the previous session, a conductive hearing loss means that the hearing nerve and the cochlear hair cells are functioning well, but there's something mechanical or conductive from the middle ear to the outer ear that's causing a blockage of the hearing. So it's more cases where the external ear is not developed, where the ear canal may not be open, where there's perforation of the eardrum, where there's fluid in the middle ear space, or those small hearing bones inside the ear are absent or not functioning. All those pieces cause blockage or a mechanical problem transmitting the sound from the outside world to the cochlea and the nerve, but the cochlea and the nerve are functioning well. In those specific instances of this conductive hearing loss, that's where something like a bone conduction hearing aid or a bone anchored hearing aid would be very beneficial. So in this image, you get a small schematic drawing of the scalp, where the red is the skin, the white beige layer is actually the subcutaneous tissue, and then you get the schematized drawing of the bone. There's two stainless steel pieces that you can see in those images. The one that's anchored in the bone is actually the implant, and in the surgical technology, that's called a fixture. Those pieces are made of pure titanium. They're only about 3 or 4 millimeters in size. And surgically, we actually screw that implant into the bone. The reason they're made of that specific metal is that this is what we call an osteointegrative technology. So the bone will actually grow attached to that titanium implant. And that's the key piece that rigidly secures the system into the bone. That's important because these devices, in contrast to a traditional hearing aid, work by vibration. And somehow you need to send the sound vibration from the external world into the bone of the skull and the inner ear, so that those vibrations then stimulate the cochlea and in turn the hearing nerve. So that osteointegration, that bony attachment of that first piece, is really key, and thankfully that technology has evolved to the point where that should be in the high 90% range for successful osteointegration. The next piece that you see in that schematic diagram is another metallic post, and in the technical lingo that would be referred to as the abutment. That abutment or post screws into the fixture or implant in the bone and actually protrudes through the skin for just a couple millimeters. That provides that percutaneous or outside the skin attachment site for the hearing aid. And that's the last piece in that diagram. That box-like structure with a little beige post on it snaps into the abutment, and then that completes the BAHA system or bone-anchored hearing aid system. That external piece that in this picture is gray and black is what contains the digital microprocessor, contains a microphone, also contains the actuator or the piece that vibrates, and it notably also contains the battery that supplies the power for the system. So in that external speech processor, that picks up the sound, converts it into a vibration, which is then conducted through the post down to the implant in the bone. The remarkable thing about this is that the sound quality is superb. Amongst all the different hearing aid technologies that we have, people will come back and say that the sound quality of people, the music that they listen to is just spectacularly clear. This is great for our patients who have conditions such as microtia and ear canal atresia, where the external ear doesn't form and maybe there is no opening at all for an ear canal. In that clinical setting, you can see how it would be difficult to fit a patient with a traditional type hearing aid. This can be attached behind where the ear should have formed, and it bypasses all those malformations and still allows the patient great access to sound and speech. The other clinically relevant scenarios where this is helpful are some of those patients who just have chronic ear infections. When you have a chronic ear infection, and let's say there's fluid in the ear or drainage coming out the ear canal, when you try to put an ear mold and a traditional hearing aid on that ear, the fluid and just the necessary pathway down to the ear canal and eardrum is obstructed. And those patients get frustrated because they can't wear their hearing aid when their ear is actively draining. If you put this bone-anchored hearing aid system in, then you bypass all that, and regardless of what the ear infection is doing, and even the impairment that the fluid is causing in the ear is bypassed by this hearing aid. Sometimes we'll have unusual circumstances where one ear may have those types of problems and the other ear is perfectly dry and naturally formed. And the patients can use a typical hearing aid on one side and they might use a bone-anchored hearing aid on the other. One of the other trends that we do more consistently these days is try to restore hearing in both ears, obviously. And so some patients will get a bone-anchored hearing aid placed on both sides. If we keep going on this line, there's various forms of bone-anchored hearing aid or bone conduction technologies that are possible. And this next slide shows you one of the different options that's just recently FDA approved here in the United States. This is called a bone bridge hearing aid. And this one's different in that the piece that vibrates with sound is actually implanted underneath the scalp into the bone directly. And so on this schematic diagram, you'll see an area where underneath the bone, there's a device that's implanted. And then on the outside of the skin, you'll see a grayish black disc. The reason for these two components is that even with an internally implanted device, you still need something on the outside world that picks up the sound and speech and transmits it to the inside piece so that it can work. That's what this external speech processor does. It has the microphone, microprocessor, and then also the power source, a battery that can be changed out as needed. The internal piece then has to receive that signal, and then it transmits it to the small canister-like portion that's furthest down and inside on this diagram. And that's the piece that actually vibrates and, again, stimulates the cochlea as well as the hearing nerve. So far, those two bone conduction technologies that I mentioned, the bone-anchored hearing aid as well as this bone bridge device, involve some type of surgical procedure. And the reality is that you need these devices typically when you're older, but because of size, bone development, and other factors like that, our very young children who need these type of hearing aids aren't eligible purely from an anatomic and size basis. So children during an early age will use these same types of bone vibrating hearing aids, but they'll simply wear it on a headband of some sort that holds it against the side of the head. Across the globe, and certainly in the United States, the age standard for using a headband-based hearing aid is up till 5 years of age. And then once you're 5 years of age, you can have some type of bone-anchored hearing aid inserted. So far for this bone bridge hearing device, this one is actually once you reach 11 years of age or older. So there's different types of intervention stages, but even when worn on a simple headband, which some of our older patients even continue to use because they want to avoid surgery, it really gives them sufficient access to sound and speech so that for our younger patients, we'll actually see excellent speech and language development as they mature. All right, so we'll go on from there. And one of the next things that is very relevant in the hearing loss domain and the different interventions we have is something called a cochlear implant, which has really become very mainstream these days. First, it's necessary to understand who is a candidate for a cochlear implant. And this will go back to the different types of hearing losses that people will show. In the previous section, we talked about those patients with conductive hearing loss and how bone conduction hearing aid technologies are appropriate for them. Let's contrast that with cochlear implant candidates where the sensory neural hearing is abnormal. And so sensory neural hearing loss refers to the cochlea and the cochlear nerve not functioning well or adequately for those patients. In that case, many of the people will have either deficient or non-functioning cochlear hair cells, or the cochlear nerve that transmits the electrical signal to the brain is not functioning well either. Those are the patients that, if they're not sufficiently helped with hearing aids, will then move on to a cochlear implant. If we're to contrast a hearing aid from a cochlear implant, remember that a hearing aid utilizes your residual hearing, and it basically amplifies it. So if you take a hearing aid and hold it up to your ear, you can actually hear the sound that the hearing aid is amplifying. Contrast that with a cochlear implant, which actually makes no sound at all. The critical difference is that a cochlear implant takes sounds and speech from the outside world and directly converts it to an electrical signal. And that electrical signal is then sent down the cochlear nerve to the brain. So if you hold up a cochlear implant speech processor to your ear, you would actually hear no sound. And if the person with a cochlear implant device in their head is not wearing the external processor that's changing the sound into an electrical signal, similarly, they're not hearing anything at all. So the components that are involved in these cochlear implants are first an external piece, which is shown on the right side. There's a piece that looks like a hearing aid with a small clear plastic hook on it, and that contains the battery as well as some of the microprocessors. Through a small cable, it's then connected to something that looks like a small steering wheel. On that steering wheel or round structure is a magnet at the center of the circle, and then around that circular piece is actually an FM antenna transmitter. So this external speech processor will pick up the sound and speech, convert it into an electrical signal, and then the transmitting antenna will send it through the scalp to the inside piece, which is on the left side of your screen. So this is the actual cochlear implant receiver stimulator that the surgeon places inside the head and is closed up and completely covered by the scalp. So looking at a person with a cochlear implant, you would not be able to see any of this portion. There's a clear silicone type rounded area, and if you look really carefully, there's a fine antenna that's embedded inside that silicone. It looks like a wire. In the center of the circular part of that device is also a magnet. So the purpose is that the magnet on the internal receiver stimulator and the magnets that's on the outside external speech processor part will lock onto each other through the scalp. It holds that external piece directly over and aligns it with the antennas so that the outside piece can transmit through the scalp very efficiently to the inside receiver stimulator. If you follow that internal component down, then you see a square titanium encased piece. And again, this has more of the microprocessors that help transmit the electrical signal into the cochlea. Coming down the bottom, then you see this small wires, and there's actually two of them. The first one is a straight piece that is purely an electrical ground, just like one of the sockets that you plug into at home. The other piece is actually what we call the array. And in this one, you'll see that it has a small curve on the end of it. This is the portion that actually gets surgically inserted into the cochlea, and it has small electrodes on it. Those electrodes are small balls, which the electric current then gets sent very specifically to different patterns of activation along those electrode arrays. What that does is stimulate specific and different hearing nerve fibers so that when those signals go to your brain, they can actually recognize what the sound and speech is coming in. A little bit complex, but one of the black box features for cochlear implantation, and truly the most fascinating part of this, is that somehow the engineers have figured out what the brain sees electrically when it hears the word boat. as a very simple example. They've been able to convert the word boat into an electrical signal that then gets sent in via this cochlear implant. And when your brain eventually sees this electrical signal, it recognizes it as boat. One of the most difficult questions that we get asked is, what is the person hearing? What's the patient hearing when they hear things with a cochlear implant? And I can couch that in a couple of examples. So the first one is someone such as myself, who's thankfully had normal hearing in both ears for my whole life. If for some catastrophic reason I lost the hearing in both my ears today, and next week I got a cochlear implant placed in my ears, I could have a conversation with you the very first time we turned on that device. Your voice would sound very robotic, very mechanical. A lot of people say it sounds Mickey Mouse-ish. And yet, even with that difficulty, I could hear you well enough so that we could hold a conversation with my eyes closed. As you work through the programming of the cochlear implant and your brain gets used to the signal that's coming in about 2 to 3 months' time, someone like myself could come in and tell you, oh, my wife sounds like what I remember. So that's somebody who is what we call postlingually deaf. So I lost my hearing after my brain had learned speech and language. I had a very short duration of deafness. So I had only lost my hearing and then gotten an implant 1 week later. That would be remarkably fast. And so those are two key features, postlingual as well as short duration of deafness. Those types of patients will do remarkably well and have the shortest rehabilitation course after a cochlear implant. Let's compare that to somebody, for example, who was born deaf, never heard, and really didn't benefit from hearing aids, so never wore hearing aids, and communicates almost entirely by sign language. If that person shows up in our offices at 40 years of age and says, I'd like to consider a cochlear implant, that person is actually a remarkably poor candidate for a cochlear implant. The statistics in that scenario are that 50% of those patients, if they do undergo cochlear implant, will be non-users in 5 years. The reasons for that is that very long duration of deafness. So in that person, the auditory nerves, the cochlea, those pathways in the brain that are relevant for hearing have all been basically unused for 40 years. Those systems naturally atrophy with time, and reawakening them or reconnecting those synapses at 40 years of age is really difficult. And at least half the time, it just doesn't work. So those people may be able to hear certain tones or different sounds, but they would never expect to get speech recognition capabilities. And so for most of those patients, that's not sufficient benefit to go through it. The challenging thing, however, is that in the other 50% of that 40-year-old population, they'll use the cochlear implant because they'll get some benefit. And every once in a while in there, you'll find a spectacular performer, somebody who gets tremendous benefit from a cochlear implant. We don't quite understand it. We think some people have this genetically inherent ability that their nerves, their cochleas, their pathways are just genetically very robust and resilient. So even after 44 decades of non-use, some reason their metabolism allows them to retain all those pathways, and they can be stimulated really well. The challenge for us clinically is that we can't tell who is going to be the non-user and who might be that rare spectacular user. So at this current stage, what we do is inform patients as to what the statistics are, and that more than half the time you probably won't be using a cochlear implant in that scenario, but every once in a while there's the possibility that you might be able to be a spectacular user of a cochlear implant. It's a really difficult decision, and that becomes very collaborative. and you have to put it in the entire picture. So those are the two extremes. We live in that middle gray zone very frequently. So for example, we'll have patients who are born with partial hearing losses, right? They're not normal hearing and they're not profoundly deaf where they hear absolutely nothing at all. And then we also live in that gray zone where patients may have used hearing aids partially. Right? The benefit about using hearing aids, even if they weren't great, is that they continue to stimulate your cochlea, your cochlear nerve, and your brain pathways. And even though it may not have been stimulated perfectly, it does still keep them viable, so that if you go down the pathway of a cochlear implant, your implant actually has more to use, and those patients definitely do better. We also live in that gray zone where people are not totally prelingually deafened and they're not totally postlingually deafened. They may have started to learn some hearing and speech and language skills, but they're clearly delayed and not up to the point where they should be from an age-appropriate stage. So introducing a cochlear implant into that middle range then produces a wide range of variability in outcomes, and it really depends upon what you bring to the table. It's one of the most candid conversations that we have, because as you talk to patients and families about whether or not they should go through a surgically invasive procedure like this, it's natural and it's proper to think about what's the benefit that you're going to get from going through this. Those gray zones that I just mentioned comprise the crux of our decisions, and trying to predict for those patients what their outcomes will be is really one of the challenging things. But thankfully, with increasing global experience with cochlear implant, it really has become the mainstay for those patients who don't benefit sufficiently from other hearing aid technologies. So the key point also is to note that before you resort to a cochlear implant, you should have exhausted the other opportunities that are less invasive, slightly less risky. And then if it's still insufficient, then you move on to the more aggressive interventions such as a cochlear implant. In the specific setting of CHARD syndrome, there's one other technology that's involved, and that'll be on the next slide. So this is something called an auditory brainstem implant. And as the name implies, this is a device that goes directly on the brainstem. It looks remarkably similar to the cochlear implant device, the internal portion, but obviously the access and the placement of this is radically different. I bring this up because it's still considered an investigational device in a lot of areas. In adults, there's a very specific small population that is candidate for an auditory brainstem implant, or ABI. And those are patients who have tumors of both hearing nerves. In those patients, unfortunately, in order to remove the tumors, the cochlear nerves had to be removed as well. Logically, if you think about it, even if you have a normal cochlea, if there's no nerve that connects your cochlea to your brain, then the purpose of placing a cochlear implant would be futile. And so in those specific patients, we'll bypass the point where the nerve is now missing and put the brainstem implant directly on the next more central or higher level of auditory system, and that's the ABI. It's relevant for people with CHARD syndrome because we see three specific anomalies in patients with CHARD. The first one is where the cochlea either is so minimally formed or not formed at all that there's no place to put in a traditional cochlear implant. The second common scenario is where the cochlear nerve is deficient or absent. So just from a congenital developmental basis, the cochlear nerve didn't form or is very minimally formed. The third one, it's very specific to CHARD, is where there's a gap between the cochlear nerve and the cochlea itself. So that causes a break in the transmission. And again, placing a cochlear implant in those types of patients is really a futile gesture. So because those three things happen not uncommonly in Charge syndrome, that's why the auditory brainstem response implant has become a key component for some centers. In Europe, I'd say the experience is greater, and there's promising results coming out from those pediatric ABI centers. However, in the United States, the experience is definitely more reserved. We'll often tell people that with an ABI, the technology and the surgical implantation is probably where cochlear implants were 30 or so years ago. We talk to patients with an ABI receiving sound awareness, but not necessarily speech recognition. So this, again, is another difficult conversation and a difficult risk-benefit calculation to execute. Some of the factors that we think about include how communicative is this child or person? If they also have something like a vision impairment due to colobomas, and you have an auditory deficiency, it's really going to impact your communication abilities. If you have any cerebral palsy or malcoordination or inability to use your hands, again, the sign language piece becomes much more challenging. And so in those factors, we try and determine what communication modality can we support for this person. Those are all really complex discussions. It takes into calculation your cognitive capabilities, all of your sensory modalities. Your cognitive potential is really very important in this. Things like anatomy from your MRI and CT scans also becomes incredibly pertinent. And putting those all together, you also have to take into the account the family perspective, as well as the overall personal potential for that person. So I think that covers the span of hearing intervention technologies that are out there. What's common in our individuals with Charge is that we'll take a brutally pragmatic approach. We typically will start with the most conservative, non-invasive options and then increase to the more aggressive, invasive options as needed. We've also become very creative. Some patients will have a cochlear implant on one side and a bone-anchored hearing aid on the other. Or similarly, they can have a bone-anchored hearing aid on one side and a traditional hearing aid on the other side. Whatever it takes to give the child as much access to sound and speech is really the goal. But always respectful of what's the primary communication mode that the family thinks they want to pursue. And sometimes if that's more of a manual visual communication mode, then the hearing technologies become less of a priority. And as we see in almost all of our families with Charge, there's constantly some issues that need to be on the front burner and others that need to be on the back burner. The one thing that we consider in families with young children with Charge is that there are some developmental time windows that are very pertinent. So in a very typically developing child, birth to 3 or 4 years of age is a window developmentally where the brain is particularly receptive to learning, hearing, speech, and language. And so we really try to exploit that window if auditory verbal communication is going to be part of the package. That's a very different scenario if you're looking at somebody who's 20 years old. That developmental brain window is long gone. And so aggressive changes at that phase are not totally useless, but we also anticipate much less brain receptivity to those types of stimulation. So another factor that goes into the overall global planning and counseling for individuals with hearing loss, particularly in the setting of Charge, that gives you a fairly replete understanding of some of the technologies that are out there currently.